Hello and welcome back to Science of Medicine. Today I want to talk about interpreting arterial blood gas results. This is an important tool that is in the arsenal of a clinician, especially for patients that have acid-base disorders, whether they be respiratory or metabolic. And it also is a wonderful example of how chemistry, in particular acid-base chemistry, is utilized in medicine. Now, the first thing I want to talk about is acid-base chemistry within the body. Now, I recognize as a PhD chemist that when we normally think about acids and bases, we think about an acid being under a Braun-Lowry definition, a proton donor, or a proton acceptor if it's a base. And I also recognize that in aqueous solution that the pH of water, 7.0, is the Mason-Dixon line, so to say, the line where above which we consider this to be basic and below which we consider it to be acidic, and neutral would be that 7.0. However, for physiology in the body, and particularly in the blood, we have the carbonic acid buffering system, and that has a slightly different set point for our neutral, if you will. So the first thing is that any time we have carbonic anhydrase, which is present in lots of locations throughout the body, including in the blood, water and carbon dioxide will very rapidly form carbonic acid, which will dissociate into hydrogen carbonate or bicarbonate plus a proton. And this is our physiologic buffering system. That pH, which is considered to be neutral in the body and in the blood, is 7.40. I recognize that 7.40 is basic in terms of aqueous acid-base chemistry. However, for physiology, the set point for neutrality is considered to be 7.40. It's not that people think that it's truly neutral, it's just that they say that's where the physiologic set point is. Anything which has a pH less than 7.40 is considered to be acidic. Anything that is above 7.40 is considered to be basic. And you may remember from general chemistry that there's a relationship that links the pH with various factors, such as the relative amounts of bicarbonate and the carbonic acid, or that is also related to carbon dioxide, using the Henderson-Hasselbalch equation. And so in this case, there's a conversion factor that relates that partial pressure of carbon dioxide into the appropriate units to be able to show this. Not that clinicians actually use the Henderson-Hasselbalch equation to calculate the pH of blood. In fact, we measure it with an arterial blood gas. Another thing that I will say is that although using a Braun-Lowry definition of an acid being a proton donor, sometimes people will say carbon dioxide and consider it to be like an acid. It's not that those people are crazy, that they actually don't know that carbon dioxide itself is not an acid. It cannot be a proton donor. However, in the presence of water and carbonic anhydrase, it forms an acid. And it is for that reason, since it's a 1-to-1 molar relationship between the carbonic acid and carbon dioxide, in the body, many times people will say, and it facilitates you thinking about things, that anytime we have a high CO2 level, that will equate to a high level then of carbonic acid, which will then cue into this buffering reaction. Now, I have two ways of regulating acid-base in my blood. The first is through the change in PCO2, which is through ventilation in the lungs. And so I have a certain amount of carbon dioxide that is normally present in the lungs. Normally that's about 40 millimeters of mercury. And I can either not ventilate that and have the CO2 rise, as in a respiratory acidosis, or I can ventilate very quickly. And by doing that, I will then have a respiratory alkalosis because that CO2 concentration will drop, therefore the carbonic acid level will drop and you will become more alkalotic. These changes in ventilation are very quick. They happen from second to second. I could also work on the bicarbonate or the H plus side of the equation, and those are regulated through the kidneys. Those are slower, and when I do that, I will also have an acidosis and an alkalosis condition. These are called metabolic acidosis, and there are numerous things that can happen within the body to generate acids, or alkalosis, where I could create bicarbonate or get rid of acid. So again, to reiterate, in the body, physiologic pH 7.40 is considered to be my neutral point, even though I recognize it is not neutral, it is slightly basic. Anything with a pH less than 7.40 is going to be considered acidotic. And as I mentioned, that comes in two forms. If it is a metabolic acidosis, I have created new protons in the body or I've lost bicarbonate. And anytime I have a metabolic acidosis, I have one of two flavors of that. And those flavors are a high anion gap and a non-anion gap metabolic acidosis. That begs the question what an anion gap is, and I can calculate the anion gap by taking the difference between the concentration of the sodium in my blood and the sum of the chloride and bicarbonate. Now, I'm not accounting for all the ions. That's why this value is not set at 0. Depends on which resource you use, but most of them will use a value of 12 as being normal if it's less than 12. And anything that would be 12 or higher would be considered to be a high anion gap metabolic acidosis. I also have the possibility of a respiratory acidosis where I retain carbon dioxide in the lungs, and therefore that leads to the generation of excess carbonic acid. And that also comes in two flavors. It comes in an acute and a chronic, and we'll talk about those later. If the pH is greater than 7.40, this sort of Mason-Dixon line here in the South United States, anything that is greater than that is considered the alkalosis, and that can either be of a metabolic or respiratory etiology or cause. In a metabolic, I'm creating excess bicarbonate or I'm losing acid. In terms of respiratory, I'm losing carbon dioxide from ventilating too much out of my lungs. Now, on the metabolic side, I mentioned that there were two flavors of metabolic acidosis, high and non-anion gaps. And the reason for being able to interpret these acid-base disorders is because if you can figure out what the acid-base disorder is, you can narrow the number of possible causes of that. It's very useful clinically. There are a number of causes of high anion gap metabolic acidosis, and this is a list, a partial list, of what's called the differential diagnosis. That's sort of a clinical way of saying what possibilities do I have for this condition. And we use the acronym MUD piles, M standing for methanol, U for uremia, D for diabetic ketoacidosis, P for propylene glycol, which is not made in your body, but people do ingest that, isoniazid, which is a medication, a drug, lactic acidosis, ethanol, ethylene glycol, and salicylate. This is various causes of high anion gap metabolic acidosis. You might wonder why. So if I look at things like methanol, ethanol, and ethylene glycol, those were all on my list, they're all primary alcohols. And in the liver, alcohol dehydrogenase will oxidize them, and they'll be oxidized to their corresponding acid. That's why drinking these alcohols can lead to an acidosis. In contrast, secondary alcohols like isopropyl alcohol will be oxidized to the ketone. There's no metabolic acidosis from that. I also have possibilities for non-anion gap metabolic acidosis, and I use the acronym here of HARD up, H standing for hyperalimentation, A, acetazolamide, R, renal tubular acidosis, D, diarrhea, and then U and P standing for abnormal connections between two places by way of a fistula. I can either connect from the ureter to the gut, that's called the ureteroenteric fistula, or from the pancreas to the duodenum, that's a pancreatico-duodenal fistula. And you may remember that the pancreas also will create bicarbonate, but it's regulated as to how much dumps into the duodenum. If you have an abnormal connection like a fistula, there's no regulation. And so most of these non-anion gap are going to be bicarbonate issues. They're losing bicarbonate, and as the etiology of that non-anionic metabolic acidosis. On the respiratory side, anything that leads to hypoventilation within the lungs, in other words, not ventilating carbon dioxide well, is going to lead to a respiratory acidosis. These things could happen on a short time scale, like for instance, asthma that normally is well controlled becoming out of control through some environmental factor, for example. That's called an asthma exacerbation. Or also people with emphysema who have an underlying, many times chronic acidosis, respiratory acidosis, can also have a worsening of this, and that's called an acute exacerbation for COPD. There are also neurologic diseases that affect the respiratory center in the brain, things like amyotrophic lateral sclerosis or Lou Gehrig's disease, Guillain-Barré, myasthenia gravis, which is a neurologic disease, but actually is when the body is making autoantibodies, not autoantibodies, antibodies to the neuromuscular junction acetylcholine receptor. Muscular dystrophy, stroke, and even central nervous system depressants like alcohol, ethanol, and Ativan or benzodiazepines. So these will cause retention of carbon dioxide, and as I mentioned before, chronic, such as in chronic obstructive pulmonary disease or emphysema. On the alkalosis side, I can lose protons or retain bicarbonate and create a metabolic alkalosis. I can lose protons a couple ways. One of the ways is that I can vomit them. I can actually lose hydrochloric acid from vomiting contents in my stomach, and that will cause a metabolic alkalosis. I also could have a hyperaldosterone state. In other words, I could have excess aldosterone in the body. You may remember when we talked about renal physiology that on the intercalated cells in the distal convoluted tubule, that if aldosterone was present, then I would reabsorb from the filtrate a sodium ion and spit out into the filtrate a proton. Thus, if I have hyperaldosteronism, I will become more alkalotic metabolically. I also can have loss of hydrogen ions from severe hypokalemia. In this case, it isn't a true loss. What happens is the potassium, which is a major intracellular cation, will come out of the cells to try to stabilize the amount of potassium that's present in the blood, and to maintain electron neutrality, I'll bring a proton in. I can retain bicarbonate also and lead to metabolic alkalosis. Chloride diarrheas, that is, if I lose a lot of chloride, such as in cholera, that will cause retention of bicarbonate. This is in contrast to the non-anion metabolic acidosis diarrheal states, which tend to lose bicarbonate. There are also loop diuretics, things like furosemide that block the sodium-potassium chloride transporter in the ascending loop of Henle. And if that's the case, you will then end up peeing out or urinating more chloride, and therefore you'll retain bicarbonate, leading to a metabolic alkalosis. The respiratory side, there's only one way that you have a respiratory alkalosis, and that is if you hyperventilate and you blow off that carbon dioxide. Blow off more carbon dioxide, form less carbonic acid, and therefore you are alkalotic. Now, I do want to point out that it's not possible for you to hypo and hyperventilate simultaneously, so we don't have a respiratory acidosis and a respiratory alkalosis acutely going on. So let's go to how we interpret the data. So any type of acid-base disorders will start with an arterial blood gas. And there are several components of this. The ones that are pertinent to acid-base are the pH, which normally should be 7.40 for an arterial blood sample, bicarbonate, which normally should be 24 millimeters of mercury, and PCO2, which should be 40 millimeters of mercury. There's also a PO2, but that does not play any role in acid-base chemistry. Note that if this were a venous blood gas, that these values would be slightly different. Sometimes I have a metabolic acidosis, and under the conditions where I have a metabolic acidosis, I have to distinguish between a high and non-anion gap. And in order to do that, I would need to have those sodium, bicarbonate, and chloride values in order to calculate the anion gap. And that might be obtainable from a basic metabolic profile. So the easiest way to learn how to interpret acid-base disorders is to go through and work problems. I'm going to try to take you through in a very systematic way of doing this, but I'm going to start with simple cases and then move to much more complicated mixed disorders. So here's the first case. A 25-year-old male has been vomiting due to a viral gastroenteritis. We've all been there. We've all had stomach bugs that cause us to vomit. So in this case, you do an arterial blood gas and you get a pH of 7.48, a bicarbonate of 33 millimolar, a PCO2 of 46 millimeters of mercury, and you do a BMP that shows a sodium chloride and bicarbonate with these values. So the first thing that you always determine is what's the acid-base disorder. How do you do that? Well, the first thing that you do is you look at the pH, always the first thing. If the pH is less than 7.40, we have an acidosis. If it's greater than 7.40, it's an alkalosis. If it's 7.40 exactly, then it may have no acid-base disorder, and I'll touch on that a little bit later on. So in this case, the pH is 7.48, we're alkalotic. Next thing, I look at the bicarbonate, and I want to look at the bicarbonate to determine if it's consistent with a metabolic acidosis or if it's more consistent with an alkalosis. So in this case, the bicarbonate is 33 millimeters of mercury. Now it should be 24, and if it were acidotic, I would expect that I would have less bicarbonate, which would be lower than 24. In fact, I don't. I have more bicarbonate, which is consistent with a metabolic alkalosis. Now I want to go over and I want to look at my PCO2. I notice that it's not that 40 millimeters of mercury that it was before. And so why is that? Well, you may remember with the Henderson-Hasselbalch equation that the pH is buffered through this system where I can change the bicarbonate and CO2. And so the CO2, by slight changes in ventilation, will try to buffer that pH so that it doesn't become as alkalotic as what it would normally do. So it moves in the same direction as the bicarbonate. And that's called a compensatory mechanism or compensatory change. And we can actually calculate this compensatory change. And there are tables to do this. This one is from Rose and Post, wonderful book on electrolyte and acid-base disorders. And so if you look here in metabolic alkalosis, for a 0.7 millimeter mercury increase in PCO2 for every 1 millimolar increase in bicarbonate. So if I go back now, I know that I went from 24 to 33 millimeters of mercury. And if I take that 9 millimolar increase and multiply it by 0.7, that gives me about a 6 millimeter of mercury rise in CO2 to the base level of 40. And this is what I actually see. This is 46. So this 46 millimeters of mercury for CO2 instead of being 40 is an appropriate compensatory change. And that should always be part of any interpretation that you make of these arterial blood gases. So wonderful. Let's try another one. We could also say, hey, the guy was vomiting, he was vomiting hydrochloric acid, and therefore I would expect a metabolic alkalosis. So let's go to this one. 25-year-old patient has been taking Xanax. She took an overdose of this, and her respirations, which are normally 12 per minute, slow to 6 per minute, and they're more shallow. So we do an arterial blood gas, pH is 7.26, bicarbonate 26, PCO2 of 60 millimeters of mercury with the BMP values here. What kind of acid-base disorder is present? So what do? We look at the pH. Always, always, always. pH is 7.26, which is consistent with an acidosis. I'm now going to look at the bicarbonate. And so if I look at the bicarbonate, 26 is higher than 24, and that is not consistent with a metabolic acidosis, which should be less. So now I'm going to look at the PCO2, and see if the acidosis might be from a respiratory cause. If that's the case, the PCO2 should be greater than 40 millimeters of mercury, and it is in this case, it's 60. And so that's consistent with a respiratory acidosis. Now, respiratory acidosis comes in two forms, acute and chronic. And so which of those matches best? So what I do is go back to that table that I showed you earlier, and I show that in acute respiratory acidosis, I expect a 1 millimolar increase in bicarbonate for every 10 millimeters of mercury PCO2 increase. So I went from 40 to 60, and therefore I would expect if the acid-base disorder were an acute respiratory acidosis, that the bicarbonate would have gone from 24 to 26, which is in fact what it did. On the other hand, if I look at chronic shows a rise of 3.5 millimolar of bicarbonate for every 10 millimeter of mercury rise in PCO2. I would have expected the bicarbonate to go up by 7. That's 3.5 times 2. And that's not consistent. It's not 31 millimolar. And so this is an acute respiratory acidosis. Clinically, that's what you would expect. The person is breathing more slowly, they're hypoventilating, and they're retaining carbon dioxide. More carbon dioxide means that there's more carbonic acid that's formed. Good. Let's do another one. So a 65-year-old long-term smoker is seen in the ER for feeling shortness of breath, and his respiratory rate is normal, but his arterial blood gas shows a pH of 7.30, a bicarbonate of 36, and a PCO2 of 75 millimeters of mercury. In addition, the BMP gives these data. What type of acid-base disorder is present? So what do? That's right, we look at the pH. pH is 7.30 is an acidosis. Next, we look at the bicarbonate. If it's a metabolic acidosis, then it should be less than 24. It is not, so it's not consistent with an acidosis. So I'm going to go to the CO2. CO2 is greater than 40. That's consistent with a respiratory acidosis. Now I have to go and look at my compensatory change to see whether it's an acute or chronic. In this case, the bicarbonate now is 36, which would be consistent with a chronic respiratory acidosis, given that the CO2 went from 40 to 75, and that there's a 3.5 millimolar increase in bicarbonate for every 10 millimeter of mercury rise in the PCO2. So this is a chronic respiratory acidosis. And you expect that also from a hypoventilating person with chronic obstructive pulmonary disease. Fabulous. Let's try this one. A 15-year-old female with type 1 diabetes mellitus has not been able to take her insulin for the last day, and she now feels ill. She's breathing rapidly and deeply. You take an arterial blood gas, pH is 7.28, bicarbonate 12, PCO2 is 26, and the BNP is as shown. What kind of acid-base disorder does she have? So the first thing we look at is the pH. 7.28 means that we're acidotic. It's less than 7.40. Next, we look at the bicarbonate. The bicarbonate is 12. That is consistent with a metabolic acidosis. Now, anytime metabolic acidosis leaves your lips, you need to calculate an anion gap, because remember, it comes in both the high anion gap and the non-anion gap metabolic acidosis. So this is the only time when I use this BMP data. Otherwise, I don't use it. So in this case, I take and subtract from 140 the sum of 100 plus 12. And that gives me an anion gap of 28, which is high because it's greater than 12. So this is a high anion gap metabolic acidosis. I'm going to go back and look at my compensatory change. I look at my table, and I see that for a metabolic acidosis that I get a 1.2 millimeter mercury rise in PCO2 for every 1 millimolar change in bicarbonate. So that's 12 times 1.2, which is 14. And so the PCO2 will try to go in the same direction as the bicarb. Bicarb went down, so the PCO2 will go down by 14. It went down from 40 to 26. Great, I have an expected compensatory change. All right, and this allows me to say, oh, I wonder what's going on. Remember, in that high anion gap metabolic acidosis, one of the things in the differential was diabetic ketoacidosis, which is consistent with this. Let's try this one. Let's move it around a little bit. Now I have the following data. What about the likely cause of this, just from these data? So I have a pH of 7.35, a bicarbonate of 16, a PCO2 of 30, and a BMP is shown here. Which of these three disorders is consistent with these data? So I still have to start and say, what's the underlying acid-base disorder? So to do that, I say pH 7.35 is acidosis. Bicarbonate is 16. That's consistent with a metabolic acidosis. Anytime I say metabolic acidosis, I calculate an anion gap. In this case, it's less than 12. It is 9. And so this is a non-anion gap metabolic acidosis. I will go through and calculate the compensatory change for the PCO2, and it's exactly as I expect. It went from 40 to 30. So this is a non-anion gap metabolic acidosis. And if you remember, there was a differential diagnosis that I had put up before that was using hard up. And on that, R stood for renal tubular acidosis. There are actually 3 types of this, and they will give a non-anion gap metabolic acidosis. Diabetic ketoacidosis does give you an anion gap metabolic acidosis, or high anion gap metabolic acidosis, and the hypoventilation from asthma attack is going to give you a respiratory acidosis, most likely acute in this case. So it's very useful to try to figure out what's going on clinically when you have these type of data, but you have to know how to interpret them. That was the simple thing. Life is more complicated. So life can also throw you mixed disorders. That is, that there might be 2 things or even 3 things that lead to a complicated acid-base process going on. However, you can solve these things because if you go about doing a systematic way of interpreting the arterial blood gas and the BMP, you can actually figure this out. So it's important that you understand that in order to do this, you need to understand about the chemistry as well as understand about the expected compensation. So I can have mixed acidosis, alkalosis, metabolic, respiratory. The only thing I can't have, yes, I cannot have a mixed acute respiratory and acidosis and alkalosis because I can't hypo and hyperventilate at the same time. Remember that the table that we have, or many tables that do exist that actually talk about these compensatory changes, are essential for solving these problems. And let's work on it. So here's an ABG, pH 7.22, bicarbonate of 16, PCO2 of 40. BMP is given here. What's the acid-base disorder? Now, pH 7.22, same thing. It's acidosis. It's less than 7.40. I look at the bicarbonate is 16, which would imply a metabolic acidosis. Anytime I say metabolic acidosis, I'm going to calculate an anion gap. In this case, it's a non-anion gap metabolic acidosis with a gap of 9. But now when I calculate the expected compensatory change, I expect that I would see about a 10 millimeter of mercury decrease in the CO2. That is, the CO2 should have gone from 40 to 30, but it did not. This is a clue that there is a mixed disorder. The carbon dioxide is actually higher than what I expect. That is, I have an overlying respiratory acidosis on top of this non-anion gap metabolic acidosis. So I have 2 acidoses that are actually causing this person's data to look like this. And I chose this just to show you because this was very similar to the last non-anion gap metabolic acidosis, but it didn't have a respiratory acidosis. I also want to point out something else to look at. If you ever see in the arterial blood gas that the pH is right at 7.40 or very, very close to it, but the bicarbonate and the PCO2 are off, you probably have a mixed disorder. Similarly, if the pH and either the bicarbonate or the PCO2 are off from their set values, but the other one is spot on or very close to it, you probably have a mixed disorder. And so those are ways that you can think about, oh, I'm going to pay attention, make sure that I do this. But if you walk through this systematic way of interpreting the ABGs, you also will be in good shape. All right, let's try some more. Here's another one. pH is 7.20, bicarbonate of 8, PCO2 of 21, BMP is shown. What's the acid-base disorder? Start off, pH, 7.20, that's acidosis. Bicarbonate is less than 24, it's therefore a metabolic acidosis. I calculate the anion gap, in this case, it's 14, so that's a high anion gap metabolic acidosis. And then if I look at the compensatory change in PCO2, I expect it to go from 40 to 21, which is what happens. But I haven't told you the whole story yet. So let me tell you the whole story now. I also have the possibility of a mixed disorder involving metabolic processes. I could have a high anion gap metabolic acidosis and a non-anion gap metabolic acidosis. Or I could have a high anion gap metabolic acidosis and a metabolic alkalosis. How do I distinguish between those three conditions? The way that I do that is I look at the change in anion gap relative to the change in bicarbonate. So a high anion gap metabolic acidosis, every time I have that, I'm also going to calculate a change in anion gap and a change in bicarbonate. And this is how I do that. So if I look at the decrease in bicarbonate, it went from 24 to 8, so the change in bicarbonate was 16. I know that I have an anion gap of 14. I expect it to be 12. And so my change in anion gap, assuming 12 is my set point, is 2. So if I look at the ratio of the change in the anion gap relative to the change in the bicarbonate, if that's 1 or actually 1 to 2, that's just your normal run-of-the-mill high anion gap metabolic acidosis. And in the previous problem that I worked, you can go back and look and see that that actually is just a high anion gap metabolic acidosis. But if that change in anion gap over the change in bicarbonate is less than 1, then I have 2 metabolic acidosis processes going on, both high and non-anion gap. Okay, both high anion and non-anion gap. And you can think about this chemically, because if the bicarbonate, which is the denominator in this, if that's a very large change in bicarbonate, but there's not much of a change in the anion gap, this ratio is going to be less than 1. On the other hand, if the change in anion gap over the change in bicarbonate is greater than 2, another way of saying that is if the change in bicarbonate is actually not that much compared to the change in anion gap, it must be that I have a metabolic alkalosis superimposed on that high anion gap metabolic acidosis. And these are ways that you can distinguish between those conditions. So anytime you find yourself in a position where you have a high anion gap metabolic acidosis, you should calculate this delta anion gap over delta bicarbonate and look to make sure that you don't have a mixed metabolic disorder. Because otherwise you really could not necessarily tell just by looking at it. Unless you've had a lot of experience, then I can look at this and tell. But most of the time you won't be able to do that unless you have a lot of experience in this. All right. As I mentioned to you before, this was what was from before when I did the type 1 diabetic here. In this case, if I calculated the delta anion gap to delta bicarbonate, it's between 1 and 2, so it's just a high anion gap metabolic acidosis. Let's do this one. A 500-pound male is sleepy, but he wakes up if you kind of try to arouse him and shake him. His respiratory rate is normal. pH 7.28, bicarbonate 43, PCO2 of 95 millimeters of mercury with this BMP. What's the acid-base disorder? So, pH 7.28, acidosis. Bicarbonate 43 is certainly not consistent with the metabolic process. We expect that to be less than 24, so I'm going to look at my CO2, which is very high. 95, should be 40. So this is consistent with a respiratory acidosis. Now I have to look at my table and see whether it's consistent with an acute or a chronic. If I do that compensatory change calculation, I find that this is consistent with a chronic respiratory acidosis. And in fact, this is called obesity hypoventilation syndrome because the mass, the weight that's actually on the person's chest is so much that it causes a restriction in the ventilation. And so this is a chronic respiratory acidosis. Wonderful. All right, let's do one more. Consider the following information. Which of the following disorders is consistent with these data? So I have a pH of 7.37, a bicarbonate of 19, PCO2 of 34 with these BMP. So first thing I always do, what's the acid-base disorder? So I look at the pH, 7.37 is an acidosis. Bicarbonate is 19, it's a metabolic acidosis. When I calculate the anion gap on that, it's 24. That's a high anion gap metabolic acidosis. Aha! Whenever I have a high anion gap metabolic acidosis, I calculate the delta anion gap over the delta bicarbonate. When I do that, I get a value of 2.4, which indicates I have both a high anion gap metabolic acidosis and a metabolic alkalosis. I then need to make sure that my expected compensatory change is there for CO2, and in fact it is. So this is a mixed high anion gap metabolic acidosis with a metabolic alkalosis. Now I need to go back and look at my different conditions. I've got a 26-year-old with the viral gastroenteritis that causes vomiting. That's my vomiting of hydrochloric acid, which is causing my metabolic alkalosis. But he's also dehydrated and has lactic acidosis. Lactic acidosis was one of the mud piles, one of the high anion gap metabolic acidosis, and therefore this is better than any of the others. 34-year-old with an acute asthma exacerbation would be consistent with an acute respiratory acidosis. Same thing for a person who was hypoventilating after taking barbiturates. And the salicylate would cause a high anion gap metabolic acidosis, but not anything mixed. Well, I hope that this is giving you a nice introduction into acid-base interpretation. I'll come back and we'll talk about some pharmacology next. And I hope you enjoy this and learn from it.